Thank you very much for coming and giving me another opportunity to be here. How many of you were there last year in my obesity lecture? So thank you again, and thank you for giving great feedback. That's why I got invited again. So last year during that lecture, I talked a lot about physiology of obesity, but to be honest, I was unable to give you good practical advice how to combat obesity and how to help yourself, other than intermittent fasting. I spoke about fasting, intermittent fasting a lot. I have, since then, I've learned more. And before I start this presentation, I just want to mention this because you were here, and I'm sure other audience who are here today, they want to learn how to combat obesity, how to avoid obesity. So there are many ways of losing weight, but we want to find a way which is safe and sustainable and does not cause starvation. We don't want you to lose weight by starving. We don't want you to be hungry. So I did find one method, and later on during Q&A, I'm willing to talk about it if we have questions. It's called bright line eating. And I'm recommending it to my patients in the clinic. And it also has the component of intermittent fasting. So bright line eating is a website, there is a book, and we have also started support group in the clinic. We can talk about it during Q&A. Today's topic is about testosterone. Testosterone is not a weight loss medication. I'm sure people have all kinds of questions about testosterone. So somebody might be thinking that testosterone can cause weight loss or can reverse diabetes. Sometimes I get those questions. It's not true. So the thing is that I have objectives which I'll be coming to, but since I've started working here, this is year 3, what I've noticed about local Fairbanks community is 2 issues. One is related to the providers. So testosterone therapy was initiated by different providers, and generally what I've found lacking is that at the time of diagnosis, adequate workup most of the time was not done to find out the reason for low testosterone. And as an endocrinologist, the most important thing for me is to find why a person has low testosterone. Is he really have a low testosterone? First question. And then if this is true that the person have low testosterone, then why they have low testosterone? The why is more important than replacement therapy. Replacement therapy is secondary. So that's one issue. The second issue is that, and that's true for any community, anywhere, because of the media. Testosterone can cure everything. That's the impression people have, which is a high feed. This is not true, so we'll talk about it. So these are the objectives. I'm going to come back to these objectives after the presentation as well. So I'm going to read through the objectives now. The idea of today's presentation is to increase awareness about different causes of low testosterone in men, to emphasize that systemic disease can also result in low testosterone, differentiate primary from secondary causes of low testosterone, to emphasize that low testosterone can be congenital or acquired, like a person can have this problem by birth or they can acquire it later during life. And when I said primary to secondary, primary means that they are having low testosterone because of a problem in the testicles, the primary organ which produce testosterone in men. Secondary is that they're having problems due to the signaling from the base of the brain, which is the pituitary gland. It's not sending the signals, or the hypothalamus above that, not sending the signals. That's a secondary cause. To emphasize that congenital causes can present at birth or even later in life. So low testosterone will cause male infertility. However, male infertility can occur with normal testosterone level. To emphasize that high testosterone level can be harmful as well. Low testosterone can be due to high estrogen. So males also have female hormones in their body, estrogen, and females also have male hormone in their body, testosterone. All endocrinology is about ratios. So if there is high estrogen in a man's body, then that can also result in symptoms of low testosterone. We will discuss age-specific side effects of testosterone replacement therapy. So this is another thing which I've seen during my practice, that when testosterone therapy was initiated, a detailed discussion regarding potential side effects of testosterone was not done. And this is very tragic in a young person, because testosterone, as I will mention here, that testosterone replacement therapy can cause infertility. So healthy aging will not cause low testosterone. Erectile dysfunction, commonly known as ED, can happen with normal testosterone level, and testosterone replacement therapy is not the only treatment for ED. Serious conditions like brain tumors can be overlooked if workup for low testosterone is not done at the time of diagnosis. I already said this, testosterone replacement therapy can cause infertility. To emphasize that prescription drugs, alcohol, street drugs, and poor sleep habits can also cause low testosterone. So these are the objectives for this presentation. And when I was thinking about making this presentation, I thought I'm going to do it differently today. I'm going to present clinical vignettes, stories from doctor's office. These are 10 different stories, 10 different patients, and every patient is going to tell you something new, and we will learn from these 10 stories. Okay? So the first story is about Iron Man. So I'm going to read this, and then I am going to give a running commentary, and I'll tell you how a doctor thinks when he saw a patient. Like everything which is happening in my mind, I'm going to say it later after reading this. So a 36-year-old pharmacist is referred for evaluation of low serum testosterone. He complains of decreased libido, decreased energy, and worsening hand pain, arthralgias. He has a 16-year-old son, but no children in his second marriage. He is taking no medications and is generally healthy. Physical exam, BMI 24, normal secondary sexual characteristics, skin is normal, no gynecomastia, testicular volume 10 ml bilaterally, total testosterone 260 nanograms per deciliter, normal is between 300 and 1000 nanograms per deciliter, LH, FSH, T4, prolactin within normal limits, cellular CT is normal, X-ray of the hands reveals costrocalcinosis of small joints bilaterally. So I just read it, but I'm going to decipher it, speak in plain English for you now. So the doctor is seeing a pharmacist. So whenever we see somebody, a patient who has healthcare background, we are trained like that we think about that this person may be self-medicating. So that's a thought, basically. Now, referral service, so this patient was identified with low T before coming to the clinic, and he's having symptoms of low T. So decreased libido, decreased energy, yes. Hand pain, which is arthralgias, means painful joints anywhere. So in this case, small joints of the hands are painful. Arthralgia is not a symptom of low T. But decreased libido, decreased energy is. So he's having low T with symptoms, fair enough. He's a young person, 36-year-old. Now, a very important question whenever we are evaluating a low T is that, have you fathered a child? It's a fantastic question, because once that person say, yes, I did, that tells you that person was born with normal machinery, 2 balls, working balls, signals coming, As I said, that testosterone supports spermatogenesis. Spermatogenesis will not happen without testosterone support. So basically, testosterone was working, signals were coming, spermatogenesis was happening, he was able to father a child. Excellent. One question, you get so much information I cannot tell you. One question. So that's a question we ask everybody with this problem. So that question was asked, and 16-year-old son. No children in second marriage. He wants to have children, so this is infertility now, male infertility. He's not taking any medications because he's a pharmacist. It's important to know that. We believe him. And he's healthy. So he's healthy. He's having these hand arthralgias. You think about like, okay, what's happening? Remember I told you earlier that systemic disease can cause low testosterone. So rheumatoid arthritis comes to mind, but he's otherwise healthy. It's a systemic disorder. So nothing else is happening to him. So something else is going on here. He is not, his BMI is 24, so he's not overweight, he's not obese. He's a healthy looking person. He has normal secondary sexual characteristics. Well, that's his body gets exposed to testosterone, we know that. His skin is normal, he's not hyperpigmented. Gynecomastia means enlargement of the breast in males. So he did not have gynecomastia. Testicular volume is 10. Testicular volume is very important. So whenever I am evaluating low T, I have to, it's important that check the balls. And when I do that, there's a way to do it. So we can do it in supine, laying down, or standing position, doesn't matter. But what is important is that in my other hand, I have beads, which are basically, so I estimate this volume of the testicles and compare them with those beads which I have in my other hand. So I estimate the volume of the testicles. The volume of the testicles is extremely important. We'll discuss more about it. So it is only 10 mil, which is small. Now they are not telling us the ethnicity of this person. So like the ethnicity affects the size of the balls. So Caucasians have bigger balls, then African American, then Asian. But the size of the balls for I didn't go to my office today, but I should have brought those cryptogenometer, that beads I'm talking about. But basically, so you have to compare the right beads with the right ethnicity. So anyhow, 10 mil is low for irrespective of the ethnicity. So testosterone level is low, testicular volume is low, testosterone is low, correlates basically. And then important thing to note is that this normal range, 300 to 1,000 nanograms per deciliter, is not age specific. So in this range, we are talking about an 18-year-old and a 70-year-old. So it's not age specific. So this can cause confusion as well, basically. Doctor, my testosterone is only 300, but it should be like 1,000. But what's your age, So then this LH, FSH are these signals which comes from the pituitary gland. They're called gonadotrophins. So they are basically, this is the signal sent by the pituitary to the testicles to produce testosterone. So whenever we check testosterone, we check these along with testosterone. We call that paired measurement. This is another very important concept in endocrinology, that when you check things in isolation, you make wrong conclusions. So whenever this is a system which is working in your body together. So whenever you measure things, you measure them together in the same blood specimen. So we do that, and we are seeing that the LH and FSH is within normal range. So this is another thing which makes endocrinology more confusing than other specialties. There's nothing as normal here. So when I read this, I said LH and FSH is within normal range, and if you will read this, you will say, yeah, they are in the normal range, but technically they are not. Why? Because testosterone levels are low. So due to the feedback, the LH and FSH should be high. So they are inappropriately normal. So they are actually inappropriately low. They should be high. So the way I explain it to my patients is that if you cannot hear me, you will ask me to speak louder. Fair? So yeah, so if the pituitary gland is not registering enough testosterone in the blood, then it will send more signals to the testicles and say, hey, produce more. You're not producing enough. So they are normal, which is inappropriate. Then CT of the brain, which is good to pick up big tumors, not small tumors, was done and it was negative. Because he was having these arthralgias in the hand, X-ray was done, and then chondrocalcinosis was diagnosed by the radiologist of the small joints. So there is a reason why Iron Man is there. Anybody wants to guess? We have any doctors in the audience? Iron Man, low testosterone, what's the connection?
He's anemic.
Hemochromatosis.
Oh yes, thank you. Thank you. Can you speak louder?
Hemochromatosis.
Wonderful, thank you, sir. So what do you know about hemochromatosis, if you don't mind? If you know the name, probably you know something about this disease.
It's iron overload, typically hereditary.
Right. So thank you for, I like discussion. I really like that. So he said hemochromatosis, iron overload, hereditary disease. Yes, all 3 points are. But this guy is 36-year-old. So this is a presentation of a disease which is congenital, genetic, but present later in life. Excellent. So that's why Iron Man is there. So this patient is having hypogonadotrophic hypogonadism. Big name. But basically what it means is that this is secondary hypogonadism. Secondary because the testicles are okay, but the signals are not coming. Although, just to make your life confusing and make my life confusing, is that the hemochromatosis can cause both kind of hypogonadism, primary and secondary. It's just the disease. But here we are identifying him as, based on the labs, hypogonadotrophic hypogonadism due to hemochromatosis. The screening test for hemochromatosis is serum iron saturation with ferritin. That's a screening test. If that comes back positive, we can do a genetic test to confirm the diagnosis. Now, this guy is not having skin hyperpigmentation. That happens a lot of time. Unfortunately, these diseases don't read textbook. So they never present like the way you will read about them. So you will learn more from these clinical vignettes because these are real stories of real people. If I do a presentation like basic physiology, you won't take that much knowledge as you will get from here. So you'll remember Iron Man. So basically, but people with this kind of presentation can also present with hyperpigmentation of the skin, and they develop diabetes because their pancreas get involved as well. I'm a diabetes specialist as well. So this is called bronze diabetes. And we have ruled out the pituitary tumor. Remember, he had a Seller CT or CT of the head, which did not show anything. And we have his prolactin levels are normal, so we have ruled out hyperprolactinemia. Because he had fathered a child and his testicles are more than 4 cc in volume, it confirms that he does not have congenital hypogonadotrophic hypogonadism, means that at puberty he received testosterone exposure. Now, 2 important points here. Chronic opioid ingestion. Opioids are pain medications like fentanyl, Duragesic, OxyContin, morphine, Tylenol number 3, codeine, things like that. If they're taken for a long period of time, they can cause low testosterone through the mechanism, going through the pituitary gland. They inhibit the signaling to the testicles and cause low T. And not only they do that, but a more common presentation, which I see often, is basically they also cause secondary adrenal insufficiency. That's another gland in the body situated above the kidney, produces important hormones, including cortisol, and that gland also stops functioning due to chronic opioids. So, they will have a similar presentation. Now, cirrhosis, which is end-stage liver disease, secondary to chronic alcohol abuse will have low T and gynecomastia as well. Cirrhosis from any cause will have this presentation because of high estrogen and high sex hormone binding globulin. Alcohol is directly toxic to the testicular cells. So too much alcohol has direct toxicity on testes as well. So yes.
Can I ask a question?
Yes, please.
So do you know in the history of this pharmacist if he has chronic opioid use because of pain in his hand?
No, we asked that, like, and he's not taking any medication.
But he never did in the past?
No.
Okay.
No. So yeah, but that's why I mentioned that's why we mentioned pharmacist, and that's like, you know, my commentary was like, okay, is he using any medication? So Mr. Nose, our next case. Mr. Nose, very interesting case. Always, every doctor, trust me, every endocrinologist gets very excited whenever we get Mr. Nose in the clinic. It's just the way it is. It's Mr. Nose. And I am privileged to actually most of the time it's Mr. Nose, but I have also seen Miss Nose as well, and it's just rare to see a Miss Nose. So anyhow, this is an 18-year-old boy who was referred for evaluation of delayed sexual development. He grew normally related to other siblings. However, he never experienced deepening of his voice and has not started to shave. Past medical history is remarkable for cleft palate repair. Family history is positive for a sister and an aunt with delayed puberty and abnormal sense of smell. Physical exam, BMI 32, scant facial hair, unable to smell coffee, anosmia, non-tender gynecomastia, female pattern pubic hair distribution, 6 centimeters stretched penis, testes 2 ml each, total testosterone only 10 nanograms per deciliter, 18-year-old, low FSH, LH, normal prolactin, MRI of the cella is normal. Okay, so this is, I'm going to now decipher it. So 18-year-old, basically coming to you for delayed, he's not going through puberty. So he grew well. He's actually, did they give us the height? They did not, okay. Anyhow, he grew well. Normally, but deepening of the voice, boys started having Adam's apple, so deepening of the voice didn't happen. And the hair on the face is extremely sensitive to testosterone level. So another question, remember in the last case I gave you one question, key question, about have you fathered a child? The second key question in this evaluation, in this type of evaluation, is that have your shaving frequency changed? It's very good question, basically. So when men are developing low testosterone level, their facial hair get less and less, and generally the way we know it is that, yeah, I used to shave every day, now I have to shave only once a week. And that's how it happens. So women, when they are developing high testosterone due to their own medical issues, they develop facial hair. So facial hair, testosterone connected, okay? So, and then cleft palate repair, useful information, and family history is useful because, and then another thing which we do, the way we check for anosmia, which is loss of smell, this is a pretty reliable, time-proven, reproducible way of doing it. There are more complex ways of doing it, but basically most of the office have coffee somewhere. And then you blindfold the patient and then ask them to smell coffee and something else. And they won't be able to smell coffee. And coffee smell, it's like lovely, and you can smell coffee, so they won't be able to smell coffee, and you can reproduce that. Another question is that I ask, can you identify food by aroma? They said no. So non-tender gynecomastia, enlargement of the breast, female pattern pubic hair distribution, basically like that. It's not like diamond shape. 6 centimeters stretched penis. Penis is small. Testes are small. testosterone levels are very, very low. So now testosterone levels are low, but this person should have high FSH and LH, basically. Because if you cannot hear me, what will you ask me? To speak louder, right? So low testosterone, then the FSH, LH should be high, should be. They're low. So that tells you that there is a problem there. Signal is not coming. Prolactin is always checked, it's normal, and we did rule out any structural disease of the pituitary gland. So here, this is a presentation of congenital hypogonadotrophic hypogonadism. So this is another big word. Hypogonadotrophic hypogonadism is basically a secondary problem, secondary hypogonadism, and called Kalman syndrome. So it's a syndrome, and patient is lacking GnRH, gonadotrophin releasing hormone from the hypothalamus. So this is above the pituitary, hypothalamus secreting GnRH, as a result of which the pituitary is secreting FSH and LH. And it's just a congenital absence. The cells did not migrate where they should go. And as I said this, I've seen a female patient, but the male to female ratio is 5:1. And genetic testing is the next step. And I've diagnosed several young patients with this disorder. It's always exciting to pick up a new patient. I'm telling you, it's just something to it. And I've seen a female patient. So, okay, azoospermia can happen with normal testosterone. Azoospermia means no sperms. So this is a 35-year-old male who was referred for infertility evaluation. He had unprotected sexual intercourse with his wife for 12 months. His wife had a child by a previous marriage. The man is healthy and takes no medication. His semen analysis reveals no sperms. Physical exam, well virilized and muscular man, no gynecomastia, 25 cc testes bilaterally, and no palpable vas deferens. Total testosterone 400 nanograms per deciliter, FSH, LH, prolactin within normal limits. Okay, so I'm going to read this for you now. So basically, 35-year-old male, now he's coming for infertility evaluation. I do see patients for that as well. He's 12 months as based by definition is infertility workup should be done. And in men, it's a simple test. Semen analysis is the only test you need for infertility evaluation, basically. And generally we repeat it several times, 3 times. Then based on that, if that is normal, you don't need to do anything else. That's it. But female infertility evaluation is much more complex. So anyhow, and then this was done. It was confirmed, reconfirmed that he has azoospermia, no sperms. Physical examination, he looks very healthy male, younger than his age. No gynecomastia this time. Testicular volume is normal. His testosterone levels are appropriate. His FSH, LH, prolactin are appropriate and normal. So appropriate is more important word for me than normal. Normal can be inappropriate as well. So what's going on? I already gave you a clue in the picture, if you can see it, how well you can see that. So can you read that small print next to the lungs?
Does it say cystic fibrosis?
Yeah, thank you for checking out from there. So the most important thing here is that, so as I told you that the things which are very, very important in the evaluation of low T is the testicular exam. So when I'm examining the testicles, I am not only checking their size, but I'm also checking whether there are lumps on the testicles or not. Lumps are important to feel if they are palpable, other than size. The consistency of the testicles are important to note. Then above the testicles, the epididymis is important, like can I feel that? Then epididymis, I'll show you a picture in a while, and then the vas is palpable, and the varicocele, if present, should be palpated. These are the things which should be palpated in the scrotum. Hernia, we can always check that. The penis and the hair distribution is looked at. So normal hair distribution, pubic hair distribution is important. Then the size more than the the penis was looked whether circumcised, uncircumcised, and where is the meatus, the urethral meatus, the opening through which the urine comes out is present. Is that the right place or not? Those are the things we looked at when we examine scrotum. So here, this is a classical presentation of cystic fibrosis. Congenital absence of vas deferens is common in men with cystic fibrosis and may be the only clinical manifestation of this genetic disorder. So again, it's presenting later in life. He's not having pulmonary symptoms. Next step will be genetic testing. Anabolic steroid use will also disrupt spermatogenesis and will cause azoospermia and infertility, much more common presentation. And these patients will have small testes and low serum gonadotrophin levels. So their FSH, LH levels will be low, testes will be atrophied. Basically, they will be very muscular men. Can I tell you a story? I don't want to digress, basically. That's why I made slides. I can speak without slides, but I'm itching to tell you a story. So I was working in Madison, Wisconsin. We got a consult. And it was sent by a local family practice guy. These are the only details I know which I'm telling you. So the idea, when we see consults, we get the labs before consults. So his testosterone, he was on intramuscular testosterone, and his levels were in thousands, very, very high, 5,000 or something like that. So the deal was then and testosterone is a controlled substance. You cannot buy it over the counter. I'm going to tell you the testosterone which is available can be harmful for your liver, but the good testosterone is very tightly controlled. You need a DEA license to get a testosterone prescription. So basically, he was getting it prescribed by a doctor, by a family physician, and then somehow he was abusing it, and they were sending to endocrinology to sort this out. So basically, I got that consult, and I basically told the nurse that let the patient know that I will not be prescribing him testosterone the way he's using it. So one thing which I do is that I do not prescribe testosterone for lifestyle reasons. Absolutely not. Basically, the only testosterone prescriptions I write are basically when somebody have low testosterone, we will replace it to an age-appropriate level, and then we do it correctly for right reasons with the right preparation for that person. We do follow up on that, and we make sure that the person is not having side effects. So anyhow, that message got conveyed, and he did not show up for his appointment, and I was very happy. So basically, I remember a colleague of mine, he used to say this, that some patients make you happy by showing up, and some patients make you happy by not showing up. So basically, I was extremely happy when he did not show up, because I was like, this encounter is not going to go well.
Excuse me. A couple of those you have down there for genetic testing, is that because if it's genetically caused, there's nothing you can do? Or?
So cystic fibrosis diagnosis will be confirmed through cystic fibrosis gene. There is one single gene, it's a single gene disease, and we can basically identify it through.
So it identifies the cystic fibrosis, not whether, okay.
Right. So he's producing, he is producing sperms. So yeah, there is a technique called IC, through which the sperms can be retrieved from his testicles, and then these sperms can be used. But you need to make the right diagnosis first. Without making the right diagnosis, you cannot offer the right treatment. Diagnosis is the key. Okay, let's go forward. Yes?
If you treat the cystic fibrosis, will that help the test? That won't affect visibility.
It's basically, so what is missing here is this, I have it here. So this is missing. This vas deferens, this is missing. This conduit is missing. So this is where the sperms needs to go. Yeah. But if he's producing sperms, his testicle size is good. He's producing sperms, and that can be retrieved. So men with breast. Men don't have breast, but so this men have a breast. So 35-year-old architect came for evaluation of gynecomastia. He describes normal libido and erections, but he has painless breast enlargement since puberty. He shaves weekly. Past medical history is remarkable for hypothyroidism due to Hashimoto's thyroiditis and a history of mumps at age 16. Physical examination, height 6 feet 2 inches, BMI 23, decreased facial hair, normal axillary and pubic hair, 4 centimeter bilateral gynecomastia without galactorrhea, normal penis without hypospadias, testes are firm, small and firm, measuring 3 cc, total testosterone 200 nanograms per deciliter, free testosterone is low, LH and FSH are high with FSH to LH ratio, high ratio. Semen analysis shows azoospermia again. So let me read it for you, this time in English. So 38-year-old architect. So basically he does not have any cognitive dysfunction. He is an architect. So we are not thinking about syndromes which can cause cognitive dysfunction as well. This is a long-standing gynecomastia. So gynecomastia, again, the onset is very important for gynecomastia. When we are evaluating gynecomastia, which is enlargement of breast in males, when did it happen is important. The most common cause of gynecomastia is drugs. So basically, but his is insidious, going on for a long period of time. Libido is normal. He's having early morning erections is another very important question for evaluation of low testosterone. Erections, which occurs spontaneously, is due to surge in the testosterone level. Testosterone, we're going to talk about it, follows a circadian pattern. So basically, but he has painless breast enlargement since puberty. He shaves weekly, not daily. His past medical history is remarkable for hypothyroidism due to Hashimoto's thyroiditis, which is an autoimmune disease of the thyroid. So he has that, which tells you about some connection. Then he had mumps at age 16. Not all children who have mumps develop mumps orchitis. Mumps can cause inflammation of the testicles, which can result in infertility, but not always. He's very tall. He's lean. BMI is 23. He's not even overweight. Decreased facial hair, normal axillary pubic hairs, 4 centimeter bilateral gynecomastia without galactorrhea, so you can press the nipples. Men can also have discharge from the nipples. I've seen it. So that is not happening here. Normal penis without hypospadias. So hypospadias is the meatus, the opening through which the urine comes out on the underside of the penis. That's hypospadias. So that's not the case here. Testes are small and firm, so consistency-wise, and they're small. Total testosterone is low for his age. Free testosterone is low. Then the FSH is very high, and semen analysis shows azoospermia. So to correlate, these FSH, LH hormones are also present in females. And the single test which we do to confirm menopause or premature ovarian insufficiency in females is FSH. So the same FSH can be used here. So here you are dealing with a man who has low T with very high FSH. So think of male menopause. But 38, so this is obviously not natural. So this is a classical presentation of Klinefelter syndrome. Klinefelter is equivalent to Turner's in men. Turner's woman, Klinefelter men. So it's a chromosomal disorder resulting in primary gonadal failure. So basically primary means primary to testes, testicular failure. That's why the testes are small and firm. The next step will be to do a chromosomal analysis. And this cartoon here tells you that how these patients look like. So what happened is that like the patients which I have seen of Klinefelter, I have not seen a classical patient of Klinefelter. I've only read about them. And I've seen a lot of patients, I'm telling you. But I have seen Klinefelter, but the Klinefelters which I have seen, they're all mosaics. So what does that mean? And that's a way more common than, or the classical Klinefelter which you will read in textbook. As I said, the diseases don't read textbook. So basically, so mosaics are like these patients who, when you do chromosome analysis, then all the chromosomes are not affected. All the cells are not equally affected. Some are not. These are called mosaics. So they present later in life. So they are, at this age they present, and that's way more common. That I've seen many of these patients. So they are missed, basically. And so this is what I was talking about. So if a workup is not done properly, then these patients are missed. They're put on testosterone and end of the story. Like why you have a hypogonadism? I don't know. Okay, men with high estrogen. So you know estrogen is the female hormone, testosterone is the male hormone. So this man has high estrogen. So a 33-year-old man is having decreased libido and breast tenderness for 6 months. He is otherwise healthy and takes no medication. He fathered a child who is now 3-year-old. He denies taking testosterone or anabolic steroids. Physical exam, BMI 23, well-virilized, muscular male, 4 centimeters, slightly tender gynecomastia, 15 cc testes bilaterally without any nodularity. Total testosterone 220 nanograms per deciliter, estradiol 195 nanograms per deciliter. Normal is between 10 and 65 for males. FSH and LH levels low, prolactin normal, serum HCG undetectable. Okay, so now I'm going to read it for you. So 33-year-old came with decreased libido. That's a symptom of low testosterone. Breast tenderness, yes, for 6 months. 6 months is important. So before that, he was healthy without these symptoms. He's otherwise healthy, takes no medication. Remember, I told you the most common cause of gynecomastia, enlargement breast in males is basically medication. So he's not taking any medication. He had fathered a child, so we know that everything was working. Child is 3-year-old. He denies taking testosterone or anabolic steroids. Anabolic steroids or testosterone. So there is a principle of energy conservation in the body. So whenever you administer any hormone, the body stops producing it. It conserves energy. These are very complex molecules. A lot of ATP is used in making these molecules. The body said, we have enough, don't have to make it. Just shut down the production. So when testosterone is given, the body stops producing its own endogenous testosterone. So he's not taking anabolic steroids, which works as testosterone or testosterone replacement. Physical BMI is 23, is very basically healthy, not overweight or obese, well-virilized muscular man. So gynecomastia is present. Testicles are small, no nodularity. Nodularity is important to feel. Total testosterone is low normal. Estradiol is super high. So where is this coming from? So look at the numbers. So the normal is up to 65. He's 195, super high. And then the FSH, LH levels are low. So, okay, so the FSH and LH are not driving this, right? They're low. Estradiol is high. So FSH, LH is not driving it. Something else is driving it. So we checked the serum HCG, which is basically another hormone produced by the placenta, but it can be produced by tumor cells. So, we looked at that, but that came back undetectable. So something is driving it. This estradiol either is produced by his body or it's coming from outside. There are only two possibilities, basically. So it's, and that's causing a symptom. Remember, I told you in that objectives that low testosterone can be due to high estrogen.
If you take testosterone boosters or whatever that stuff is they sell over the internet now, would it then cause the FSH to be your body to quit producing that?
You don't know what so testosterone booster is something, that's snake oil, basically. So, but if you take testosterone, remember it's a controlled substance. You cannot buy it like that. If you're buying the real deal, they will, because it's a controlled substance, you have to pay way more. than what you get through. So anyway, so this man presents with high estrogen, low testosterone, low gonadotrophin. Gonadotrophin means FSH, LH levels. And even if, so the more very important point here is that even if the testicular exam is unremarkable, because this high estrogen, this person most likely have a testicular tumor, Sertoli cell or Leydig cell tumor, which we are unable to palpate. So this is endogenous estrogen. It's coming from somewhere. So then the next step would be to do a scrotal ultrasound. So just based on the labs.
Dr. Ahmed, can't men also have high estrogen from gut dysbiosis and
No.
gut infections? But what about all these men who are obese who don't have?
Well, we'll talk about that. But no, gut dysbiosis will not cause. I'm actually reading up on gut dysbiosis, and if we have time, I'm going to tell you something fascinating which really is not in public knowledge yet, and I am very concerned about it. But hold that question. But no high estrogen now. I'm reading about it right now nowadays. Actually, that's why I'm pretty. That's why that confidence is there, because I'm reading about it. Okay, so number 6, testosterone can cause side effects. Very important to know, because these side effects are never talked about. Testosterone is like, okay, testosterone, go on testosterone, you'll be fine. And then who's talking about side effects like here? And they happen. So this is a 25-year-old smart, astute male, was diagnosed with Klinefelter. Remember that architect we talked about? So this is like that presentation. He's a smoker, and he have a family history of dyslipidemia. Physical exam, BMI 25, blood pressure 145/85. Normal secondary sexual characteristics, bilateral non-tender gynecomastia. That's a part of this. Okay, I'm not going to. Let me read. 6 cc testes bilaterally, hematocrit 44, normal is between 38 to 45. Total testosterone 150 nanograms per deciliter. LH, FSH high. LDL cholesterol is 155 milligrams per deciliter. HDL 40 milligrams per deciliter. Repeat testosterone came back low. He wants to know side effects of testosterone before starting testosterone replacement therapy. Smart person. Okay, so this is just a presentation of Klinefelter. Basically, this is a real patient. That's why he's smoking. His blood pressure is high for his age. So basically, the hematocrit is high. And he has family history of dyslipidemia. His numbers were checked as a baseline. And he wants to talk about the side effects. Fair enough. So next slide is really important. So acne is the most common side effect of testosterone replacement therapy in young men, but acne is rare in older men with testosterone replacement therapy. Testosterone therapy is associated with the dose-dependent increase in hemoglobin and hematocrit. This is very important, and this is much more common in older individual than in a younger individual. In younger individuals, we give them IM testosterone without worry, because this effect hardly ever happens in a younger individual. But it is way more common in an older individual. And this is important. This is very important. Because why? Because basically, when hematocrits start increasing, the flow of the blood change. It is no longer laminar. It becomes turbulent. So when it goes through the small blood vessels, it forms blood clot, which can go. So that phenomena is called thromboembolic phenomena. Blood clots can happen. And then it also increases blood pressure. This guy already have high blood pressure. So then this young person is also smoking. Smoking causes hypoxia. Hypoxia causes compensatory erythrocytosis, which is basically high hematocrit. So when you want to prescribe testosterone replacement therapy to a smoker, be careful, basically, because you have to monitor and make sure you're using the right preparation, because otherwise there will be issues here. So this is the oral alkylated androgens that can cause hepatotoxicity. So this is the stuff which you can buy over the internet, cheaper stuff, basically. But we don't, all the testosterone preparations which we prescribe, none of them can cause any liver damage, basically. Most of these are anabolic steroids kind of stuff. Testosterone therapy can improve mood. However, too much can cause steroid rage or testosterone rage. Common. And this testosterone can decompensate a mental stable illness happens. So one has to be careful, like, what you are doing, to whom you are prescribing. You may get a call from their psychiatrist. What are you doing? And plus, you are responsible if that person decompensate or did something wrong to himself or to the community. You decompensate that guy. So testosterone can lower LDL cholesterol in all age groups. That's a good thing. LDL is the bad one, bad cholesterol. And then only in younger men it lowers HDL, but in older men it has minimal effect on HDL. It has no effect on triglycerides. Remember, this young man has a history of lipid disorder in his family. He wants to know. Testosterone will not cause prostate cancer. However, it can make it grow and spread faster. So screening for prostate cancer before starting testosterone replacement therapy and while the person is on testosterone replacement therapy is important. Testosterone therapy, replacement therapy can increase estrogen level, resulting in gynecomastia, hot flushes, and possibly blood clots. The blood clots thing is basically relevant clinically if they are having a history of thromboembolic disease previously, or they have any genetic marker or genetic factor result, positive for thromboembolic phenomena. Then that's an issue. So testosterone does not cause sleep apnea, however, can make it worse. That's very important too. I don't have a vignette here, but it's not uncommon consult in my office that somebody puts somebody on testosterone replacement therapy because they are having symptoms, which they can attribute to low T. But then after starting testosterone replacement, they started feeling worse. And so much so that that they end up in my office. Afterwards, it happens often. And one of the reasons is that they had obstructive sleep apnea, which is a common disorder. And Dr. Clay Triplehorn was here earlier speaking about that. Then what happened with testosterone replacement therapy is that mild will become moderate will become severe. And because of that, and they're not treated for that, so they basically end up sleeping poorly, they have more hypoxia, they are more tired, they're more fatigued, they are basically, I am worse on testosterone replacement therapy than I was before. Happens all the time. So testosterone replacement can be given to people with obstructive sleep apnea, but they have to be treated. So I frequently send consults to Dr. Clay Triplehorn and appreciate his help. Okay, so number 7, high testosterone can be problematic too. So this is a 29-year-old male, complains of recent onset of gynecomastia, decreased libido, and ED. He takes no medications. He states that he drinks a couple of beers every day, and he denies using anabolic steroids. Physical exam, BMI 21, well-virilized and muscular men, bilateral gynecomastia, normal penis, testes 15 cc bilaterally without any palpable abnormalities. Total testosterone 950 nanograms per deciliter, normal is between 300 and 1000 nanograms per deciliter. Estradiol 195, normal is between 10 and 65 for males. LH, FSH is low, prolactin is within normal limits. So basically what is happening here? So this is a 29-year-old, he's having gynecomastia basically. So remember, breast is an estrogen dependent tissue, both in men and women. If somebody is having enlargement of breast, basically that's estrogen. So just without checking, I know that this person have excess estrogen. So women who get more exposed to estrogen during puberty have bigger breast. Women who get less exposure have smaller breast, basically. Women who have something else going on, when I'm evaluating, I ask about the breast size. without have to look at the breast. Just breast cup size helps me to know how much estrogen exposure that woman or girl had at the right time, because that tells me that. So, okay, so a couple of beers and no anabolic steroids. BMI is 21, he's lean, well virilized, muscular male, bilateral gynecomastia, normal penis. Testosterone is good. Testosterone is very high actually. It's high, but estradiol is also very high, and that is causing his symptoms. So when estradiol is high, it also causes another thing in the body. So it increases the production of sex hormone binding globulin in the liver. And total testosterone, my friends, is not an important number. Because total is the total of all the kinds of testosterone a person has, basically. The more important number is free testosterone. So free testosterone is the testosterone which actually works at the level of the tissue. And so basically the free will be, if more is bounded, less will be free. So basically, so if we checked his free testosterone, it should be very low, although his total testosterone is like 950. So that's another way of low T presentation, that somebody have normal total T, but low free T. And then there is also a bioavailable testosterone. So low free T, low bioavailable testosterone, basically high sex hormone binding globulin, and basically they will have symptoms of low T. So something like that is happening here. His LH and FSH is low. So like, where is this testosterone coming from? So total T is 950, LH, FSH is low, prolactin is normal. So what is the driver here? Where is this coming from? He's not using it. He said that he's not using any exogenous testosterone. So high serum testosterone level associated with low gonadotrophin levels seen with HCG producing tumor. So this is another abnormal hormone, basically, which is produced by the placenta normally. But so HCG is used for in different diets for weight loss, basically therapy. Testosterone abuse. SCG can be produced by tumors, so this is a possible presentation of tumor or SCG abuse. Testosterone abuse, anabolics, and what is testosterone abuse and androgen secreting Leydig cell tumors or adrenal tumors can also cause that. The next step would be to check the HCG level. We need to find the driver. So something is driving that. If this is not exogenous, not coming from outside, it's coming from inside, so something is driving it. LH and FSH is not driving it, something else is driving it. So what is that something else? So if it is SCG, once we identify SCG, then we start looking, okay, what's the source of this SCG? Okay, number 8 of 10, so bear with me. So healthy aging will not cause low testosterone. Look at this guy. Oh yeah, look at him. He's standing on his arms only. So a 75-year-old man is evaluated for erectile dysfunction, ED. He reports good energy levels, no decrease in libido, and no headaches or visual field disturbances. He plays tennis 3 to 4 times weekly. Bless you. His past medical history is remarkable for chronic hep C and hypertension. His only medication is thiazide diuretic for hypertension. Physical exam, blood pressure 140/90, BMI 22, labs taken in afternoon, total testosterone 225 nanogram per deciliter, LH, FSH, prolactin, T4 are within normal limits, liver enzymes are slightly elevated. Now I'm going to read it for you. So he's a very healthy 75-year-old, and when you get older, then your age does not matter. Your functional status matters. So that's how I evaluate my patient. I ask their functional status. So his functional status is excellent. And he's complaining of ED, but he has great energy level. He's not complaining of decreased libido. So another thing I'm going to demystify, you will see these ads. Take testosterone, whether prescription or whatever, basically, and get rid of the ED. That's baloney. Trust me. I treat these patients, I know. It can happen, but the one thing for sure which will happen with testosterone replacement is that libido will go up. And there are times, a lot of times, ED does not get better. but libido will definitely go up. If you're giving enough testosterone, libido will, that's this desire, will go up. Whether ED will get better, maybe, sometimes, but not always. So here, so for me, libido is more important to, as a symptom when I ask, I want to know more about libido than ED. Patients wants to talk about ED. So basically, so here he is saying my libido is good. So that's great to hear. 75-year-old, ED is there. No headaches, no visual field disturbances. He played tennis 3 to 4 times weekly, so a lot of energy. Unfortunately, a lot of Americans get exposed to hepatitis C because they were not screening the blood. He's 75-year-old, probably in that age bracket. And so that's unfortunate. Hypertension can happen with aging, unfortunately, but he is only treated with a single agent, thiazide. His blood pressure is not very well controlled. His BMI is great. You can see how healthy he is. And labs were taken. So this is another point here we are making, that the labs were taken in the afternoon. Remember we talked about that the testosterone follow a diurnal rhythm. So testosterone levels are not straight line throughout the day. They change. So in the afternoon, his total testosterone is 225. That's great number in the afternoon for a 75-year-old. Probably it's 30 points higher if we checked it in the morning between 8 and 9 fasting. Water allowed. So this is a great number. And remember, his libido is okay. So just by looking at it, I know that this is not a low T issue. LH, FSH, prolactin, thyroid are all fine. Liver enzymes are slightly elevated because he has chronic hep C. Now, the other thing is that the medication, remember the medication is very important. So the medication he's taking, thiazide, can cause ED. So it's a poor choice for 2 reasons. One, he's having ED because of his medication, and other is look at his blood pressure. It's not very well controlled. So we want to optimize his health. He has done great. We want to keep him healthy as long as he lives. So thiazide probably is not the best choice. We have much better medications, antihypertensive therapies available. We'll change his therapy, problem solve. Okay, so this healthy 75-year-old male is not reporting generalized weakness, decreased muscle strength, decreased vigor, and decreased libido. ED is unlikely due to decreased testosterone. This can be confirmed by checking his fasting, early morning total, and free testosterone between 8 and 9 a.m. Okay, so testosterone is not the only treatment for ED. 62-year-old men with diabetes for 10 years complains of ED. He had minimal tumescence with 5 trials of 100 milligrams of sildenafil, which is Viagra. He's happily married to a healthy woman who is interested in sex. He reports a normal libido. He jogs for 30 minutes 4 times a week. He has hypertension and dyslipidemia. He takes ramipril, atorvastatin, metformin. Physical exam, BMI 29, well virilized. Male, normal cardiopulmonary exam, 20 cc testes bilaterally, normal neurological exam. Total testosterone 290 nanograms per deciliter, FSH, LH, and prolactin with the normal limits, A1C 7.3%, TSH with the normal limits. How can we help him? So diabetes, 10 years, duration, diabetes, so there are 2 questions important for diabetes whenever we're dealing with diabetes. What kind of diabetes a person have? Most of the time they're misdiagnosed. Trust me, it's very common. That's one of the things I want to talk if we have time. Then the other is duration. So tumescence is less. Basically we ask this question, did you achieve enough tumescence to achieve a penetration or not, basically. That's the question. So Viagra is not working, 100 milligrams decent dose. He has not tried Cialis or Levitra. Relationship is important. Basically, anxiety can cause problems as well. So that's not the case. Libido is normal. He's high functional status is good. These medications, the 3 medications, will not cause him to have any problems with ED. BMI is, he is not obese, and virilized cardiopulmonary exam is normal. They are telling you that for a reason. Testicle size is decent. Neurological exam is normal. They're telling you for a reason. Total testosterone is okay. A1C is slightly high. Thyroid is normal. So what we can do? So 50 to 70% men with ED experience improved erectile function with oral phosphodiesterase type 5 inhibitors, PDE type 5 inhibitors, which are basically Viagra, Levitra, Cialis. They act by decreasing the degradation of cyclic GMP that increase penile levels of nitric oxide and cause vasodilatation required for tumescence. Alprostatal prostaglandin acts directly to increase the cyclic GMP level. Alprostatal is given as an intraurethral capsule or as an intracavernosal injection. So you can see that injection. This is self-administered by the patient. So, but it is for sure it kind of works basically. So the important things about these drugs are that these are really safe drugs. They're not unsafe drugs. I don't know why they're expensive, basically, but and I don't know why insurance companies limit the amount that you can have. Who are they to decide that how many times you can have sex? So, but that's the way it is. It doesn't matter what prescription I write. They dictate that we will have only 2 pills a month, 3 pills a month. Really, different insurance companies have that kind of thing. I don't know why. So I prefer Cialis basically because Viagra is the shortest acting. I like Viagra in patients who have coronary artery disease basically, and I prefer Viagra in that population. But otherwise, I prefer Cialis basically. It's a 36 hours drug, so you don't have to go and get your blue pill. So it works in the system. So after taking a Cialis or a Viagra, person will not have spontaneous hard-on. They have to be with the right person in the right circumstances to achieve that. They work better on empty stomach without food and alcohol. Priapism, which is erection, which is not going away, that is basically just talked about. It's not real. That's not a real side effect. The more common side effects is basically transient changes in the color vision, some sinus symptoms, backache, slight. These are slight symptoms. The more important thing, which is a public message, is this, that these drugs have drug interaction with nitrates. So basically, if somebody has these medications in the system and they were given nitrates, which are given for relief of chest pain, nitrates can be given as a paste, can be given under the tongue, can be given as oral or by the injections. Then drug interaction can be so severe that their blood pressure can plummet and they can die. So whenever I prescribe these medications, I tell the patient, document it, it's a medical legal issue, that it's your responsibility or your partner's responsibility to tell the paramedics, tell the doctor you have this drug in the system so they don't use the nitrates. They can still treat you for chest pain without using nitrates. And then basically, so that kind of things does not happen. It's very important. And so I never prescribe these medications without talking about it. So then last case, low testosterone can be due to a brain tumor. So a 34-year-old man was found to have a low testosterone of 134 nanograms per deciliter when evaluated for ED. I don't know what this is typo. Prolactin was subsequently found to be 11,420 nanograms per mil. Normal is between 4 and 23 nanograms per ml. And the MRI shows 3.2 by 1.7 by 2.8 centimeter macroadenoma invading the cavernous sinus and wrapping around the right carotid artery. What is its prognosis and treatment options? And you can see the tumor here basically. So the optic chiasm is pushed to one side, the pituitary gland is pushed to one side. This is all tumor invading beyond the cavernous sinus, and the carotid arteries, which are visible in red, and the normal cavernous sinus in the blue, that's also pushed, and the tumor is wrapping around. So this is macroadenoma. It's not uncommon. So basically, pituitary tumors, any tumor arising in the pituitary gland, basically, are treated exclusively by medications or by surgery or by radiotherapy or by a combination of these treatments. Now, this person presented with prolectinoma, which is very, very successfully almost always, not always, but almost always treated with medication. The medication which we use nowadays is called cabergoline, and with proper treatment, this tumor can go away completely, cured. It takes time, depending on the size. But basically, these tumors can be producing other pituitary hormones as well, other than prolactin, and that needs surgery. Most of the time, these are non-functional tumors, basically requiring surgery. We can do pretty well with these tumors. In the right hands, basically transphenoidal surgery in the right place, where we don't do it here in Fairbanks. They do it in Anchorage, I was told. But good surgeon, high volume surgeon, and even if they develop problems with the pituitary gland, we can replace all those hormones. The condition is called panhypopit, but we can take care of that. And these patients in good hands, they do very well. And sometime after surgery, they need continuous medical therapy for acromegaly, growth hormone tumors, basically, or Cushing's disease that needs medical therapy or radiotherapy, depending on if they're able to resect the tumor completely or not. But again, we can take care of it. Okay, so again, go over the objectives. I did talk about that low T is not about testes. There are things beyond testes. So I want to increase the awareness that there are causes. There are a lot of causes for low T. Systemic diseases should not be forgotten, that they can cause low T, and there can be primary or secondary causes of low T. There can be acquired or congenital causes. Congenital causes can be present at birth or later in life. And then low T will cause male infertility. However, male infertility can occur without low T, with normal testosterone level. Too much testosterone is harmful in men too. Low T can be due to high estrogen. High estrogen is not normal in men. Men don't have breast. We did discuss age-specific side effects. Side effects are important. Side effect profile is important. Healthy aging will not cause low T. ED can happen with normal T, and testosterone replacement therapy is not the only treatment for ED. Serious conditions like brain tumors can be overlooked if workup for low T is not done at the time of the diagnosis. Testosterone replacement therapy can cause infertility in young men. It's important. So basically, if young men are coming with low T and they want fertility to be preserved, they need to be treated differently. They can be treated, and we can treat them, but basically identify them, have a discussion, and I don't trust them. I don't trust young women, I don't trust young men. No, I do. I'm telling you from experience. When they tell me they're not interested in preserving fertility, I said, you may change your mind. So I don't. And the same thing with the females, basically. They change their mind. I've seen that many, many times. So for me, you want to preserve the fertility. We emphasize that prescription drugs, alcohol, street drugs, and poor sleep habits can cause low T as well. So basically, I'm open to questions, all questions.
Can you talk about the estrogen thing that you were going to talk about when I asked about gut dysbiosis?
Right, we'll hold it till the end, because that is, but I want to answer more specific questions regarding this presentation first. Yes, sir.
Do you have any thoughts on Clomid or clomiphene?
Yes, so when I was talking about basically treating young men who wants to preserve fertility, clomiphene citrate is one of the therapy, and I've used it successfully. So what does clomiphene does? Clomiphene basically, through the feedback loop, increases the FSH and LH levels. You can actually see the FSH, LH before treatment and after treatment. And if the more important thing for clomiphene to work is basically Remember I was telling you that it is very important to feel the testicles. The volume is important. Now, if the testicle volume is okay, the clomiphene will work. But if the testicles are atrophied, shrunken, gone, clomiphene is not going to work. The other problem with clomiphene is that I generally titrate the dose, start with a very lowest dose and gradually increase it after 2 or 3 weeks. At higher doses, it's difficult to tolerate because of nausea. But it's a good drug when it's tolerated. When it works at a low dose with the right testicular volume, it works, voila. It's like you can see the testosterone level. Works nice. Yes, any other question? Yes?
You go ahead. Oh, okay. Talk about testosterone replacement in women. Is there some rationale or good science behind the use for that? I know it's become fairly popular.
So again, I don't want to put you on the spot, but I was expecting this question and I had framed my answer basically, and this is a part of my answer. So, but again, I'm not putting you on the spot, but tell me why you want to treat a woman with testosterone.
I wouldn't, but the ways it's been used in the past, my understanding, is it helps to increase libido in women. And that's the main reason I'm aware of that it has been used in women before.
Okay, good. I was expecting you were going to say that. But there are 2 reasons to give testosterone to women. One is what Dr. Swenson just said, to increase libido. As I told you earlier during the presentation, the one thing with testosterone will do for sure, it will increase libido, the desire. It may not help with the ED, but it will definitely increase the desire, both in men and women, basically. So, and the second reason to treat women with testosterone replacement is basically if you are doing transgender therapy. And I have patients in my clinic right now where we are doing it. So it's interesting to see that, because basically all the side effects I'm talking about, they want those things. So that's interesting, kind of. So use it. So basically, my answer to your question, sir, is this, that there are 2 medications available. One arrived in 2015. It's not very popular. It's called Addy, A-D-D-Y-I, Addy. And the reason it's not popular is basically because there is a drug interaction with alcohol. It can cause very low blood pressure if it is taken with alcohol. This medication is female Viagra. It increases the sexual desire in females. And the second medication is going to be released in September this year. It's called Vyleesi, V-Y-L-E-E-S-I. This will be a blockbuster medication. That's what I read about it, Vyleesi, September 2019. And this is injectable. It has no problems with alcohol, and this drug will cause increase female libido, and longer acting drug like a Cialis. So very exciting drug, available for females, much more cleaner therapy than testosterone. So I will use these drugs for hypoorgasmic disorder in females than using testosterone. Remember, the friendly hormone for females is estrogen, not testosterone. The friendly hormone for men is testosterone. You don't want to give estrogen to men. You don't want to give too much testosterone or testosterone to women. I do prescribe testosterone to women, by the way, in my clinic. I do. Let me tell you who are these patients who get testosterone prescription from me, and I'll tell you what are the challenges. So what happened is that you'll be surprised to hear this, that after menopause, ovaries stop producing estrogen, right? That's when menopause is. But they continue producing testosterone. And postmenopausal women actually have higher level of testosterone than premenopausal women. That's true. So women who have bilateral self-angioophorectomy, means removal of both the ovaries. We have big population like that. I check their testosterone levels. They're very, very low, and I do replace them. And I replace them to an age-specific range, basically. And I check the levels from time to time to make sure they are not higher than what is normal for females, which is much lower levels than men. And the challenge here is, I have this discussion with a patient that I'm doing this for you. It will increase quality of life issue there. That's about it. Nothing more. They like it. I said, okay, you can continue taking it. But the other issue is that all these preparations are for men. So women needs less testosterone. So if you use any of the men preparation, you cannot get the level which should be in the normal physiological range for them, for their gender. You cannot get that level. So you end up using compounded therapy. So all these patients are, there was a doctor named Roca protocol. This is North Pole Pharmacy used that, and this is the protocol I use, Roca protocol. And I check the levels because some women start putting more, and then my nurse called them, your levels are up, what are you doing? So we don't want them to have too much testosterone. So yeah, but that's the only population which I prescribe. And I check the levels before prescribing and during, but otherwise not. Yes, ma'am, you had a question.
Well, just curiosity, for the prescription testosterone, and I could ask again, but you said this of estrogen as well, where does it come from? Is it natural? Is it created?
Synthetic. Yeah, synthetic, but synthetic, what it is natural, this synthetic is, again, this is a big debate, you know. What is natural in the community is not natural, basically. It's coming from animal source, but this is synthetic. Yes?
What's your application of choice? Injections, creams, patches?
Right, good question. So I didn't discuss that. So basically, as I said, I have no problem in giving IM testosterone. So IM testosterone is technology of 1950s. And the way I explain it to my patients is that let's suppose, sir, you take 2 Tylenol every day, okay, for aches and pains, safe medication. And thank you, sir. So basically, so I ask you to take 14 tablets of Tylenol today so you don't have to take it for 1 week. If you follow my advice, it will going to mess up your liver. Okay? So basically that's what we do with IM testosterone. We give them 2 weeks worth of dose in 1 day. Or even 1 week. We have protocols, 1 week, 2 weeks, 4 weeks protocols basically. But it is not physiological. Our body never produced testosterone like that, never. So when we want to replace testosterone, we want to replace it in a normal physiological way, how the body produces it. So these IM testosterones, I don't like them. And I told you earlier that the rise in the hematocrit is dose dependent. So they causes most increase in testosterone in hematocrit basically. So, but I have younger patients who are on this, I have no problem. It's a standard dose which I use. But the modality of choice which I have is basically gels. So the YA gels basically daily application. The testosterone level go high, then they plateau. There's no peak, and then then at the end of the day they're done. This is more physiological. The contact issue is not a big issue in real world. I talked about it when I prescribe it. And we check the levels. We documented that your levels goes up when we prescribe the gel. Prescription gels are better. They're expensive. They are better because you get a consistent amount of testosterone. The compounded gels are very cheap, but the problem is that the level is not, the testosterone in the compounded gel is not consistent. Levels, we check the levels, so we know. So they're good sometime not. That's the way it is. Yes, sir.
So I guess I want to ask if this is correct. So men who see low testosterone who are older but are obese, testosterone is getting converted to estrogen in their fat cells. So if you lose a bunch of weight, then theoretically your testosterone levels, your free testosterone levels go up.
Yes,
Okay.
that's true. So that is another thing basically that to happen is that like when we are treating obese hypogonadal person, whatever reason is, we expect, because what happened that around 10%, this 10% is a ballpark figure, it varies from person to person, there's a range. So that 10-14% of testosterone will always get converted into estradiol by the adipocytes. There's enzyme in the adipocytes called aromatase which will do that. So basically then they will be, because there are more number of adipocytes maybe, they will have higher estradiol. And you expect that. So I basically check their estradiol. In this population, what I do, I check estradiol before starting them on testosterone. So I know what's the change. And if they're not complaining of high estrogen symptoms, it's fine. And then another thing is that how much testosterone you're giving. So if you're giving like bolus amount of testosterone, you're getting more estrogen on the other hand. So again, most of the time I can get away by managing the dose of testosterone. Aromatase inhibitors are also a therapy, which if you're going to read about this topic, they say you really cannot like prescribe testosterone without inhibiting the estrogen and all that. But the thing is that read about the side effects of aromatase inhibitors. This is a drug which is given after breast cancer to prevent recurrence of breast cancer. It is a very strong drug. It can cause osteoporosis. It washes away the bones. Low testosterone can also cause osteoporosis in men. This is a cause of osteoporosis in men. You're basically increasing that person's problem by giving them aromatase inhibitors. I'm not very fond of giving aromatase inhibitors. It's not that I am not familiar with that drug, that I cannot manage that. I can do that. But in my mind, I'm just causing this to become more complex. I'm doing a replacement therapy here. That's what I'm doing, right? Somebody has low T. I'm trying to help that person to live a more healthy life. And I am giving a very, like a chemotherapy kind of drug, what I'm doing here. Yes, ma'am.
What was the name of that drug again that's given after breast cancer?
So aromatase inhibitor is the name is the class. And aromatase inhibitors, there are 4 or 5 of them basically. Arimidex, I believe, is the most common one.
And it causes bone loss?
It causes severe osteoporosis. Severe osteoporosis. Yes, sir.
Besides the BMI, when the man gets older, what about exercise? Is that levels of testosterone?
It can improve testosterone. Yes.
So more exercise, better levels?
So more exercise is not important. Regular exercise is important. I tell this to my patients. There are certain things which I repeat every day in my clinic. Every day. These are the, and that's the regular exercise is more important than more exercise. Whatever you do, just do it on a regular basis.
Does the type of exercise
Doesn't matter.
Aerobic versus interval training?
Doesn't matter. If you're not doing it regularly, end of the story.
Aerobic would be better than anaerobic?
Both has their own benefits. Both have their own unique benefits, basically. So basically a combination would be better if you're doing it. Because with aerobic, you are not keeping your muscles and bones healthy. Yes, sir.
And once you start therapy, can you not come off of it because it will compound the previous problem that you had? I mean, is there a danger? Like some medications, they tell you, boy, don't stop taking it without consulting your doctor because it's going to...
So this is a very good question, actually. And why this is a good question is that a lot of people were started on testosterone inappropriately. When I look back at their labs, go back if those labs are available, their testosterone levels was reasonable, but they were started on testosterone by somebody. And then when I do my exam and check their testicles, they're atrophied. They are like small beads. They're gone. Honestly, because remember I told you this principle of energy conservation that the body stopped producing testosterone, so the organ which produced testosterone started shrinking and getting atrophied. It's gone. So when it's gone, now this person is really hypogonad. They have testicular hypogonadism. That's what I document in my note, that this is the volume, it's gone now. So if we stop testosterone, now testosterone is also very important for, I didn't say this, I should have said this. So it's not all about sex. For older men, testosterone is extremely important, even if they are not sexually active. It's extremely important for the health of their bones and their muscles. Extremely important, basically. And it is evident when you take it away. So there are patients in my clinic who I said, I want to prescribe you testosterone. Please accept this prescription because I want to keep their bones healthy. But I use that, I remember when I prescribe it, I make sure that it is age appropriate because I can harm them by giving them too much, and that's not the intent. So I take care of that. And so these patients should be on testosterone because they are like now iatrogenic hypogonadism. Yeah. So, yes, you.
Okay, there was one more question over here, and then maybe address her question.
Yes, we'll close that.
So, in your 75-year-old slide that you have there, he had high blood pressure, right? And complained about ED. Is there a relationship there?
So remember, he was taking thiazide diuretic. So that diuretic was causing ED.
Okay, but is outside of that, can there be a relationship between blood pressure and...
Right, so if he has vascular disease, but in that slide, basically, we mentioned that the cardiopulmonary exam is normal. So basically, but if he has peripheral vascular disease, that can cause it. So another thing, I'm going to tell you another very important thing. So is that people who are developing heart disease, before they develop heart disease, they develop ED. And why? Because atherosclerosis, which is a disease of the intima, which is the inner lining of the blood vessel. The inner lining of the blood vessel is same everywhere in the body. It's not any different in coronary arteries than anywhere else. And the caliber or the diameter of the arteries in the penis is smaller than in the heart. They get affected before. So if somebody develops ED due to vascular compromise, now ED can be due to many reasons, but if it is due to vascular compromise, that is basically that they're developing atherosclerosis, causing ED, and then later on develop coronary artery disease. So, common. You know, this is like in hindsight, yeah, I had ED, but I never mentioned, I thought it's aging or this and that or whatever. Okay, I'm going to answer your question now. Okay, I have a few minutes. Okay, this is a fascinating thing. This basically if you invite me again, I can do another presentation. This is a really important public message. The public message in one word is this. And I'll give a little bit of explanation too. Artificial sweeteners are bad for you. This is a single word, okay? But the story behind it, which needs a whole presentation, and I'm working on it, reading about this topic, and I'm going to present somewhere else, but can be done on this forum as well. So basically, in the old times, and I'm not that old, you're not that old, but in the older times, basically, there used to be two kinds of diabetes. Type 1, which used to present in early childhood, and type 2, older person get it later in life. Now, there are a lot of diseases. There's not one disease, but there are a lot of diseases which are evolving. They're changing. I know several of them in my field. And type 1 diabetes is that disease which is evolving, changing. Now, type 1 diabetes is atypical. It is presenting in adulthood in obese males and females. Now, how can you explain that? That's why these patients get misdiagnosed, not get treated right, and I see them. I see them in bulk. That's like my job. That's what I do. So I know about this. So basically, we call it LADA, L-A-D-A, atypical type 1 diabetes, very common. The prevalence, so the genetic, there are 50 genes associated with type 1 diabetes, and they are not increasing in population. So that genetic pool is the same. So what is increasing the incidence of type 1 diabetes? Type 1 diabetes used to be a rare disease. It's not a common disease, but it's the incidence is increasing, and presentations are, trust me, very atypical, very atypical. Like you need an endocrinologist to work them up, like that they're so atypical. And that's why the treatment it becomes more complex, that because as I told you earlier, the diagnosis is the most important thing. If you don't diagnose it correctly, you cannot treat it right. So what is happening? So we know the gut flora now very well. And we also have good papers where people have documented that how this flora is unique for type 1 diabetes. They have identified that flora. And they have also identified that how that gut flora causes type 1 diabetes. The mechanisms, they literally have worked out the mechanisms. I've read those papers. So this is what I was talking about. So if you Google the artificial sweetener industry, it used to be a few $1 million. It is $5 or $6 billion worldwide. And it's an easy sell because I can sell it to you if you are the health manager for a community. I'm going to come and tell you that sugar is harmful for your community in so many ways. And if you use artificial sweeteners, it will not increase hemoglobin A1C, true statement. It will not cause dental caries or cavities, basically, true statement. And, all these sugar texts can be avoided when you're using artificial sweeteners. You will buy it. Everybody's buying it. But it is causing dysbiosis there. That is the thing. And this is not in public knowledge yet. And it is in susceptible individuals like who have those genes, it's causing atypical diabetes. Plus, it also causes insulin response. So when we take artificial sweeteners, the taste buds get activated, and they cause insulin release. Insulin is released when we think about food normally. Think about food, not eat started food, not even smell food. Think about food. That's the normal physiology for insulin. So basically, they cause insulin. Insulin is the hormone which causes obesity. So that's why there is not a single study ever. People have tried this, that why people are not losing weight when they use artificial sweeteners. Nobody has shown that. That's not happening. Why? Because insulin is released once these artificial sweeteners are used. And then if you check the FDA website, that these artificial sweeteners are not completely safe. They are safe at a specific dose. Nobody talked about it. Nobody tell you how much Splenda you can use. Nobody talks about that. So they are safe at a very limited dose. After that, you're on your own. So that's the point I was making. Artificial sweeteners are not safe.
Is that to distinguish between plant-based sweeteners?
Yes, sir. Absolutely. So my recommendation as an endocrinologist, if you have to have sugar, have a little bit of honey.
That eliminates Truvia.
Yeah, all the sweeteners, ma'am. Don't drink them. They are really bad. None of them are safe, basically.
And none of the diet things ever say how much artificial sweetener is in them.
Yeah. They only give you the name. Yeah.
We don't know how much we're taking if they are dose-dependent.
Yep. Okay. So thank you for coming. Thank you so much.
What about the sports drinks, Gatorade, Powerade?
Artificial sweeteners. So you should drink sugar if you have to, cane sugar, honey, those are the things. But artificial sweeteners are not good.
Gatorade uses artificial sweeteners.
Artificial sweeteners are not safe, sir. That's statement I stand behind.
What about stevia? It's not artificial.
That is artificial sweetener.
It is.
So, so if something is plant-based, it doesn't mean it is safe, I believe cyanide is also plant-based.